Thank you very much. Allow me to share my screen. All right, thank you very much, and thank you for the introduction. So, as mentioned, I'm Vivian Korir, Program Manager for Capacity Strengthening with Digital Squared Path, and I'm based out in Nairobi. I'll start the presentation, then I'll welcome my colleague Moses and my colleague Alain at some point also to speak to this. So these are the objectives for this hour. Really describe the purpose, structure, and key features of the Digital Health Applied Leadership Program. Also analyze implementation experiences, successes, and lessons learned from implementation in Africa. Then thereafter, identify opportunities for adapting and implementing DHLP in Asia. And also, what are the potential pathways for collaboration, partnership, and country engagement? So really, this program started way back in 2019 when it was conceptualized in a multi-stakeholder meeting in Milton Park. And that multi-stakeholder meeting brought together multilaterals, academia, digital health implementers, private sector. I know AeHIN was part of this, and the attendees in that forum identified the need for a comprehensive country-driven training curriculum, which not only emphasizes on the digital health technical skills, but also the leadership skills. And through this is how the Digital Health Applied Leadership Program was conceptualized. So really, this program addresses the critical bottleneck in digital health transformation in LMICs, looking at the technical and leadership skills gaps for mid-level leaders. And those skills are needed to drive implementation of national digital health strategies. This program was developed collaboratively with WHO, USAID, CDC, Ministries of Health, other partners I've mentioned, including AeHIN. And it is stewarded by Digital Square at Path. To date, we've trained over 100 digital health leaders across 8 countries in Africa using a proven context-sensitive and applied learning model. So these are the key features of the program. It's a 6-month blended learning program. It's designed for mid-level digital health leaders. And these digital health leaders don't have to come only from the Ministry of Health, but other government ministries, other agencies, programs involved in digital health initiatives. So it's a highly adaptable country-driven curriculum, and it's aligned to national digital health strategies. The mode of delivery is blended, so we have in-person workshops, which are interspaced with self-paced learning and some virtual sessions. Over the course of the 6 months, there is one-on-one leadership coaching addressing individual digital health gaps. There's cross-country peer learning, and we have regional communities of practice. In-country trainers and technical mentors are utilized, leveraging and strengthening local capacity. And also in Africa, we work with HELINA. HELINA is just what AeHIN is in Asia. And HELINA works with their national association, and this is an aspect around sustainability. We deliver the program in English and French, and it is adaptable to new geographical locations. So this is the design of the program. On the far left, prior to the start of the program, we have a team of 14 to 20 participants from one country who enroll to the program. We call it a cohort. And then the Ministries of Health identify priority challenges or priority areas where the team will develop the applied learning projects. We also have leadership coaches who work with each participant to set goals, their leadership goals prior to the start. Then the cohort joins the program where they go through the training program. So a foundational and core element of this program is the Digital Health Planning National Systems, DHPNS, known to many of us. And anchored to that are elective deep dives. So what you have here, like GDHM, informatics for leaders, standards for leaders, cybersecurity for leaders, smart guidelines, and so forth, are elective deep dives which are anchored onto DHPNS. These are highly adaptable and they are not cast on stone, and we could onboard as many as needed as per the context. Alongside this, there's applied learning and there's leadership coaching. We have the regional networks, digital health networks supporting throughout the program. And at the far right are what are the results. So at the individual level, increase in knowledge and skills in digital health leadership. At the institutional level, progress in digital health priorities. And at the global level, a community of digital health leaders. These are the components of the program. So we have core components, which is DHPNS as mentioned, leadership training and one-on-one coaching, applied learning and cross-country peer learning. This is what my colleagues from Burkina Faso and Zambia will be sharing shortly on implementation of these components in the two countries. These are elective deep dives, which I've said there's room to develop based on emerging digital health areas or interests based on a country or the region. So we had a pilot in 2022-2023, and the pilot we implemented in 5 African countries: Guinea, Cameroon, DRC, Malawi, and Zimbabwe. And the pilot was 12 months. It was fully virtual, and based on lessons we learned from an evaluation done at the end of the pilot, we updated the program, and we are currently implementing, and I'll talk about that shortly. So this is a quote from an alumni from the pilot, and this quote was given 2 months ago, that most notably the knowledge gained from this program played a pivotal role in development of the digital agency framework in the country, helping them to stay focused on priorities under political pressure and ensuring alignment with enterprise architecture for universal health coverage digitization, demonstrating these programs real-world impact and value in advancing digital health leadership. We have a success story from the pilot from Zimbabwe. So through the applied learning component, the cohort from Zimbabwe, first the Ministry of Health identified a priority area, which was electronic health record system rollout. And through that, the cohort developed or designed the applied learning project alongside that issue identified and embedded it within the Ministry of Health, convened workshops and secured a partner. And post the program, they developed a donor proposal and they requested for funding, and they got funding which supported interoperability and improvements of the EHR. And this is a success story we have from our pilot. Currently, as mentioned, we're implementing the second iteration. So we're implementing in 3 countries, Burkina Faso, Zambia, and Rwanda. And the program, as you've seen, is now 6 months, and we're implementing in 2 languages. So this is just to mention the context-sensitive model of the program. First and foremost, it's very crucial that the Ministry of Health expresses interest in the program, and there is buy-in, and also they commit to participate in the program and release participants or the leaders to participate in the program. Also, the Ministry of Health plays a key role while during design and development of the program, by prioritizing the different departments, ministries, and other government agencies where the participants will be drawn from. Also, they collaborate in developing country-specific case studies. So for those of us who've done DHPNS, we are aware of the ONESA case study. So just like the ONESA case study, we have each country developing a country-specific case study, which will be used during delivery of DHPNS. Ministry also helps in identifying thematic priorities for applied learning, and this is based on their current priorities, and it's also aligned to the digital health strategy. Also, the Ministry of Health selects the elective deep dives for the country and also participates in developing country-specific training plan, meaning that the ministry agrees ahead of time on the dates when the in-person sessions will take place, and therefore doesn't conflict with other calendar, dates in the Ministry of Health calendar. So prior to the start also, we have some learning needs assessments which are done, for instance, for the leadership component, so that gaps at institutional and individual levels are identified, and the curriculum is adapted to address that. We also utilize in-country and regional, mainly in-country trainers and technical mentors, as well as leadership coaches, just furthering the agenda of strengthening local capacity and building a cadre of trainers, mentors, and leaders for leadership coaches for sustainability. Also working with, I've mentioned this, the Regional Health Informatics Association. So at this point, we'll delve a bit into the implementation experience. We'll look at the experience in implementing in these two countries. As mentioned, this is a current implementation. We started in April and we'll be finishing in September. So my colleague from Zambia and Burkina Faso will share based on, the far we've implemented to this point. So I'll invite Moses to pick up from here. Sorry.
Thank you very much, Vivian. And so I'll be speaking on 3 of the components. And to start with, I'll talk about participant selection and experience. So we had a very competitive recruitment process, which we sent out the request for application to a number of different stakeholders, and we had the Ministry of Health right at the core of selecting the participants that would enroll in the program. And so for Zambia, we ended up having 6 female participants, and we had 20 participants that were selected, and 6 of them were female. And the female were coming from mid-management up to senior management. We also had different components. We have a participant coming from one of the regulators of ICTs, and then we have another participant who's coming from the regulators of medicines in Zambia, and we had 2 participants coming from our cooperating partners, and we also have a medical doctor coming from one of our health facilities who was picked for this program. So it just goes to show that it was a very competitive process, and we had a good number of participants that applied, and we had to go through the process and end up picking those 20 that I've mentioned. And so amongst the lessons we learned was that we needed to have buy-in from MOH from the get-go, because this increases the participation and the ability for us to deliver this program. And you saw, like I said, the commitment and the competitive recruitment process was very ideal, and we had the ministry right at the core, and they ended up making the final selection of the participants. So in a nutshell, that was how we came up with our 20 participants for this program. And so DHPNS implementation and the experience that we've had, like Vivian earlier on said, we are utilizing local trainers, in-country trainers to roll out this program, and that has worked to our advantage because most of them know our local landscape, and hence when the trainings are being done, local examples are being given, and that is driving home the training. We have noticed that, yes, people, despite doing DHPNS prior, we have a number of them that did it. But because now we are applying a lot of local content, they're appreciating more the lessons that they're learning. So that is a plus that DHLP brings to the table. And we have a number, we had 2 elective deep dives that we ventured into, and these were again the brainchild of the Ministry of Health as they looked at what their digital health strategy was talking into and what areas would need more depth and understanding. And so this the DHPNS also provided core and functional element in DHLP, proving and providing a basis for applied learning and anchoring it on the deep dives. So what we also learned was that I think going forward, it would be best to embed the case studies into the content, because right now we still have the ONESA case study, and it meant when you are giving illustrations and examples, you have to rush to another page where the local case study is. So I think going forward, we would need to embed those local case studies right into the program so that when we are giving examples, we are referring to the local study. And so the applied learning experience, for me, I think is one of the major game changers of DHALP. And in Zambia, we have spent a lot more time on the applied learning because it addresses priority of the digital health problems and priorities identified by the Ministry of Health. Based on the request, these align directly with respective national digital health and current health priorities. So the Ministry of Health were asked to come up with 3 thematic areas that they thought were relevant and that would probably build into a project. And we saw, as the case of Zimbabwe, maybe even get funding for them. And so for us to achieve that, we've decided to take a little more time and effort and concentration on the applied learning so that whatever we are learning, we apply it to the local context and to the thematic areas that we have. And we took time in engaging experts and technical mentors. So for one of our technical mentors that is dealing with terminology services is one that has been in the industry for quite some time and has worked with the Ministry of Health here in Zambia, developing electronic management information systems, which is logistics for drugs. And so terminology services there would play a critical role. The other one we are working with has done a lot of work also in client registry. And you know, Zambia recently enacted the Data Governance Law, a Protection Act. So there also we've engaged a legal mind who was very pivotal to the development of the same act to come and help as a technical mentor as we look at these different thematic areas. And so the applied learning really is telling us that we need to move from theory to practice, and the participants invest the knowledge that they have acquired in DHPNS to immediately apply the lessons and to address the priorities. So the 3 thematic areas that the Ministry of Health Zambia identified were terminology services, as I said earlier on, client registry, and data governance. So currently, as we are going through this program, we are looking at these different areas and we are developing projects that will eventually can be used to solicit for donor funding.
Thank you so much, Moses. I'll invite Alain.
Thank you, everyone. My name is Alain. I'm happy to share insight from Burkina Faso in West Africa to you all, based on the three aspect. First one is the elective deep dives experience. And as my colleagues said previously, this deep dive experience, these deep dive topics were set up based on more priorities raised in the National Digital Health Strategy. And in Burkina Faso, we use a framing workshop at the beginning of the course to define and agree on those deep dive topics that should be addressed during the training. And we came up with 2 topics, informatics for leaders and standards for leaders. These 2 topics provide some basics, some concept and approaches to leaders who sometimes are not informatics engineer. And so it helped to build a sort of capacities of communication, of interaction between non-technician leaders with the informatic engineer. And also it helped to prepare the leaders to attend the discussion that the Ministry of Health is about to undertake around setting up an enterprise architecture, which may lead to a definition of a set of norms for interoperability. So we prepared the leaders, and feedback that came from them are they are getting more and more confident on speaking about health informatics, speaking about digital health, because they have learned a lot of concepts, a lot of methods, and they feel sensitized around the topics related to digital health. The second aspect of my speech will be regarding the leadership coaching experience. This is a specific aspect of this training that provided what I can say a specific added value to that training. And we have leaders, we have people playing role of leaders, but who don't really have leadership skills. And this is what we experienced we noted through the learning assessment. And that assessment showed that the top skills that will need to be built is how they can mobilize stakeholders, the partners, and resources, how they can manage the stakeholders' expectation, and how they can communicate effectively with the other stakeholders, and including partners, the supervisor, the national authorities, and any other stakeholder that may influence the decision-making for digital transformation. Another thing we learned from the assessment is the top challenge that they use to face. It's around how to influence stakeholders, how to communicate effectively, and above all, how to develop a leadership mindset. And the approach of building the leadership skills includes this in-person workshop during the session, full day session on workshop, where they learn how to define and know in new Koreans their own profile, their own weakness, their own asset, and how they can, from that profile, they can define a pathway to build the leadership profile. And after this in-person session, there is a one-on-one coaching session that each participant gets with an outstanding leader that can share his experience and accompany the participant to build his leadership regarding the pathway that has been drawn from the assessment and the profile identification. And they also receive tools and tips. And finally, the feedback we got from the participant is that they are getting more and more self-confident on how to interact with the surroundings. I mean, the colleagues, the supervisor, as well as the implementing partners, as well as the other stakeholders that may work on the digital health field with them. The last thing is about the cross-country peer learning. This is an exciting thing that participants really appreciated, because it helped to gather the participants from the 3 countries around a topic. And for the first learning session, we discussed around how to face the sustaining digital health in front of the funding disruption challenges that many countries are facing in nowadays. And for that session, there were a guest speaker who is fortunately a former digital DHLP learner. And he shared his experience from DHALP to implementing what he learned from DHALP at country level. And this gave a real sense of how the participant, our current participant, can invest what they are learning from that current session. And also, the participant appreciated the similarities in terms of challenges, in terms of assets, in terms of success, and also they appreciate the similarities of opportunities and the possibility to import solutions from similar country to their respective one, so they can address the different challenges that may raise during the implementation of a digital initiative. And also they were also interested in learning about how an alumni is reinvesting his knowledge, his skills that he had built following the digital course in her day-to-day work and in the strategic work at country level, and so on. And to conclude, I would like to share that this DHLP course at country level is helping to close the gap and to change mind, and above all to create a new what I can call a new paradigm in terms of digital health, because in the past many people thought that if we are speaking about digital health, it's a matter of turning a paper form to a digital one. It's about it's a matter of health informatics. Is informatics engineer, but from the DHLP course, we are seeing that the mind is changing, and people are knowing that it's a matter of everyone who is working in public health work. It's a matter of everyone has to provide his perspective, so we can build a real sustainable system using digital tools. Thank you. Over to you, Vivian.
Thank you so much, Alain, for that. So I'll wind up very few minutes, then we'll open up for an interactive session and questions and answer. So really, when we look at opportunities for implementing and adapting DHLP in Asia, it's more of looking at, appreciating the two contexts. There is a lot of similarities, but also we appreciate that differences in the context. And therefore, since this program is highly adaptable, and it means then adapting it for implementation in Asia is something which is possible. There are opportunities for collaboration in terms of resource mobilization, in terms of design, and in terms of delivery of the program. And when it comes to adapting, for what we've done and what we've seen work in Africa really is the tripartite collaboration. DHLP is really a collaboration between Ministry of Health, PATH, and also HELINA in Africa. So if we are talking about Asia, then AeHIN will really play a key role with their local or national associations. Then also in design of the program, including the core components and the elective deep dives, it's highly adaptable, and therefore we can, in the design, we can look into the different components and see what is relevant in Asia, what is not relevant, what can we bring on board, what can we drop, and so forth. Also potential participant profiles, and also the process of selection. Also in program delivery in terms of duration. Yeah, in Africa, we are doing 6 months. We are doing in-person sessions interspaced with self-paced learning. But when we go to Asia, we know the different contextual aspects. So in terms of, duration, delivery modalities, and so forth, which work best. Also, partners who would be the potential delivery partners, who would be the trainers, who would be the technical mentors, who will take up the leadership coaching aspect. And really key and important is leveraging on existing partnerships, models, collaborations, and infrastructure in the region. So success of this program, really, we've learned, relies on partnerships and collaboration. So like Ministry of Health, Health Informatics Association or network, in-country associations, as well as delivery partners. So in this next phase, we are exploring then countries in Asia who might be interested in this, and as well as would benefit from this. And very important, as I mentioned earlier, the interest from Ministry of Health is paramount before we proceed with any steps. So I think that is a starting step, and also collaborating with the partners, including AeHIN, to map potential donors, to implement resource mobilization activities, to collaborate in design of the program, and to collaborate in implementation of the program. So really that is what we had today for this session. So to introduce this program to you, different stakeholders in Asia, and then open up this for an open session. We can interact, you can seek clarification, you can ask questions, and you are welcome at this point. Thank you.
Thank you, Ms. Vivian, Sir Moses, and Sir Alain for the presentation and introducing DHALP to the AeHIN community. To our members, if you'd like to ask questions or clarifications, please feel free to send your questions in the chat or raise your hand so we can call your name. Yes, Sir Jai.
Thank you, Cha. Thank you, Vivian, Moses, and Alain. It kind of makes me nostalgic. It takes me back 6 years when we were working on the conceptualization of this DHALP as part of the consultation at Wilton Park in November 2019, which you mentioned, Vivian. It's very interesting how the program has grown, evolved since then. And a couple of things at the time that we were able to bring it during the consultation was the importance of selecting the right people and being able to retain them, because DHALP is a long journey, unlike many other courses that are few weeks or days. Here the momentum is to be sustained over the period of a few months, and you mentioned like 6 months. So one of the important thing is like typically in the government, especially when there is a leadership change and the whole set of senior management changes, and then the people in whom we build the capacity, when they move out, there are impacts. In AeHIN, like we have a decade plus of experience building the capacity of the MOH leaders in the region. So it's important to select the right people who are going to be there for substantial number of years to make the difference after, and then also being able to put to use what they have actually learned or kind of developed during this course. So that was something that we brought, and in fact, selecting the mid-tier people in terms of hierarchy, not too low, not too high, because these two are important. Means the senior people are likely to change because of various factors, and then also the lower rung, it's difficult to get into the decision-making roles. So that, in fact, the suggestion came from us, and then also like what could be more appropriate, bring the ground level experience in terms of the learning, and being able to whatever is learned is able, like they are in a position when after the DHALP cohort completion, they should be able to actually get things done in their own country. So that is something that I remember bringing it to the table, and then glad to see the developments, and very happy that you are able to share the experience. And then also thanks, Pat, that keen to collaborate with us in the region. Of course, like we look forward to work together and then see how we can bring it to the region. And let's have some questions. I'm sure that there are a lot of participants who have joined. Please feel free to raise your questions. And then like if there are any things that Vivian and team would like to actually clarify, that will be great to have here. Thanks again, Vivian, and the speakers Over to you, Cha, and then the audience for any questions that you might have.
Yes, thank you, Sir Jai. I think there's a question from Dr. Aminul. Dr. Aminul, would you like to speak?
Yes, thank you, Cha. So, thank you for excellent presentation. So, thank the Vivian and her team. So, my first question is: so, did you customize the DSPNS course for your region, or it's directly the DSPNS course default that is available? That is my first question. And there is a one survey that you mentioned that the participants you take the feedback, but did you take any survey after the practical exposure or implementation of the participants? How was the performance? Who are in the courses and who are not in the courses? Did you any cross validations of their knowledge level, or how they perform in the real time digital health transformations in the region? So these two questions I have. Thank you.
Thank you very much, Dr. Aminul, and thank you also, Jai, for the feedback and learning that you are part of the DHLP journey. Jai, was something really exciting, and you've been in this program longer than most of us. So back to the question from Dr. Aminul. Yeah, so for DHPNS, really, we are using the program as is. The only adaptation is the case study. So we develop country-specific case studies. So we are aware of the ONESA case study. So each country really develops a case study collaboratively with the Ministry of Health. And just like the ONESA case study is used across the program, then that is where the case study is used. Also anchored onto DHPNS is applied learning. So what it means is, as soon as the participants learn Module 1 of DHPNS, they start applying learning to solve a Ministry of Health priority. And so there's that immediate application of learning in real world to address real world challenge. Also anchored at the deep dives. So we have modules, DHPNS modules where we have deep dives. So if a module, for instance, has a deep dive, it means once you cover that module or at a certain point in the DHPNS module, then you do the deep dive. So I think those are some of the adaptations or additions to DHPNS. I talked about the survey, which we did. It was an evaluation at the end of the pilot, which really informed, the adaptations we've done in this iteration of the program, which we have currently. For instance, the program was 1 year, it was post-COVID, it was fully virtual. The feedback we received is 1 year is very long, and that's why we were able to design and reduce to 6 months. Getting participants to participate, in a virtual program for 6 months also is not easy. So we saw very high dropout rates in the pilot. But now when we have the in-person interspaced with virtual learning, we are seeing good transition rates. I think the lowest now, and we are towards the final sessions, is 80%, but there's a country at 90%, there's another country at 85%. Competitive recruitment was another feedback we received to get that commitment from the participants. And we have also learned during this implementation that competitive recruitment also helps in participation. If participants were to be nominated, there are those who wouldn't get an opportunity. But with open recruitment or call for recruitment, it means they have an opportunity to apply and they will be considered in the program. We've not done really follow-up beyond, besides the Zimbabwe case study where we learned that they were able to apply, use the applied learning project and now seek funding, which went ahead and, they got funding and implemented post the program. That's one of the, learnings we followed through. And some and alumni we're in touch with, like for instance, the one from DRC, we sharing, how the program is helping them and has helped them in the past. But we've not really been able to do a follow-up study. But perhaps as we move towards completing this iteration, those are some of the things we are looking at post the program, and even going back to even those who are in the initial program to see what is this, the impact really of the program. Thank you.
Vivi,
Thank you.
If I may just add to what you shared. I mean, one of the things that, we had this discussion when DHALP was evolving, when the curriculum was being developed, and DHALP as well as DHPNS, it all actually started from Africa. So it was, all these things evolved with almost the same set of teams. And then, so DHPNS is like, for example, like DHALP, the cohort could bring, participation from across multiple ministries. Like one of the things that came from AeHIN was like, we said not focus only on the MOH, but there are other ministries that are relevant for digital health, because digital health is inherently multidisciplinary. So we may have participants from other ministries who actually contribute or work together with the Ministry of Health in supporting the national digital health programs. So also bring in them and then kind of pin them. Like for example, the Ministry of IT participants or Ministry of Communications and Development or other ministries that can actually work together with Ministry of Health, and that becomes more meaningful in terms of the national digital health programs. And they can also have like a capstone project, they can work together. And DHPNS like primarily is like a 101, right? So it's like a primer because people come from variety of backgrounds, and so to actually bring them all to kind of somewhat on the even ground, DHPNS was actually used like a 101. So everybody has a different level of understanding in digital health. If we can bring the cohort more even or more homogeneous in terms of understanding, that's something that was discussed. So I thought I will bring that to the table. And then there is also, like for example, Vivian, like in our region, we also had DHPNS delivery from AeHIN. And then we had 5 people also trained as a TOT together with Path and USAID support. So and then so we do have people who could actually take it further if and when the DHALP evolves in our region. And AeHIN actually has official nominees from over 14 countries currently. And these are people actually nominated by the governments. So that way, like we would say that there is already a core team that could probably contribute if and when this program evolves in our region. And then I do see a couple of other comments also. So let's take more questions and comment. I see something from Nirmal Lakal from GIZ Nepal. Are there any other questions?
The question from Sir Nirmal reads that the challenge or issue that are collected in the beginning, are they addressed through selection of elective course only or customized based on the challenges? Basically, how are the challenges addressed?
Thank you very much. So as I address the questions, for the DHPNS TOT, which took place, I remember Dr. Minu was part of it. We were also part of it with Alain, so it's good to connect again. So the challenge or issue that are collected at the beginning, what we mentioned as the thematic priorities for applied learning or issues, are they addressed through selection of elective course only or customized? So we have the elective deep dives, and also we have the applied learning projects. Applied learning projects are like capstone projects. But unlike capstone, which is done at the end, the applied learning is started from the first module of DHPNS. So yes, those challenges and issues identified are used to design projects, applied learning projects, and over the course of DHPNS and with the guidance of the trainers and the technical mentors, then they are able to come up with solutions or potential projects which could get some funding, as Moses mentioned. Yeah. Then also somebody has asked, could you estimate how long it's gonna take to be localization in terms of language? for digital health sessions, could be since many Asian countries don't have English or French as native languages. So what has really been advantage for the countries we've implemented in Africa is their French and English, and the core component is DHPNS, which is already available in English, French, Spanish, and I think 2 other languages. So if it is not available in that language, that might take a little bit more time. But the beauty also is now we have, softwares which could quickly translate, content, and then all we need is review to be able to adapt it to for delivery in the region. So perhaps I might not have an answer now based on, I don't know whether the DHPNS is available in the common language in Asia. If not, then we might have to see how that would go. But I think it's possible to translate quickly. All right, the grassroots or mid-level will not be likely to learn another language to get or involved. I think it's possible to translate to another language. That is possible.
I can add just one particular thing I'm aware of, Vivian. So we did, of course, the training in English, but I know our Mongolian colleagues, I see one of them actually joined here also. So there was this effort to translate DHPNS course into Mongolian. So that was also happening. So I'm aware of that. Probably it's possible that, it depends on someone taking interest. And among those who have already participated in the course, and then taking and working together, so it's kind of like 2 hands, 2 palms coming together. So we need to have people from those countries also taking interest and supporting in the local language versions, because there could be many other languages than what is initially thought of or developed. Yeah, that's just something that I am aware that in Mongolian at least that effort was made.
Thank you, Ms. Vivian, Sir Jai. Are there any more questions or comments from our participants?
There's one on the chat. I don't know if I'm getting the question. The question is, my question is about the pool of speakers for the program, how to select, collaborate in your experience. I don't know whether you mean the trainers in the program, DM?
Yes, I mean the trainer.
Oh, so for the trainers, what we did, there are different sets of trainers. So there are those who do the DHPNS, applied learning, and elective deep dives. That is the technical aspect of digital health. So what we utilize are the DHPNS TOTs who are trained, I think in 2023. So we had a number of them who in turn trained those who had not been trained. And then for the leadership component, we engaged an expert in leadership, which is an organization which is delivering the leadership component across the 3 countries. So that's how we've done the selection. And I think it's been mentioned that there are a number of DHPNS TOTs in your region, and also there are persons who've been identified across the different countries also for DHPNS. So that is where you would start from, those already trained as TOTs for DHPNS. For the technical aspect, for leadership, then it would mean seeing how best to approach that.
Yeah, I can share country-based experience from Burkina Faso. In addition to the DHPNS TOT participant, for instance, myself, we are collaborating with additional trainers from country to, for instance, health informatics lectures at the public universities. So, and also we are collaborating with other additional digital health experts as mentors, meaning that we are trying to leverage local expertise in addition to the DHPNS trainers that I'm part of, to to set up a pool of traders that support this training. And also, I would like to mention also that in order to have a pool, speaking of a supply gauge, long gauge, we used to have a preparation session prior to each in-person workshop. We used to hold a preparation session. So we can learn the language of DSPNS, and we also can learn about the overall component of the training and the different model we will have to deliver during a given session, and so on. So this is why at country level, we managed to collaborate between different digital health specialists coming from different entities. Thank you.
Thank you, Moses. I think we are at the top of the hour. If there are no more questions, I think we can conclude now. And of course, we should also have a group photograph on this occasion. And I would like to really thank Vivian. We know we have been talking for the last few months, but really it's very interesting to see how DHALP has evolved. And then thanks to you speakers like Moses and Alain, that you share the experiences from Africa. And then please feel free to keep bringing us more updates. I think I also heard the September, right? So please do actually keep sharing the updates, and then you could also post it to AeHIN listservs for our members. And then we do eagerly look forward for further developments, and then also see how we can work together to take this program to our region. And thanks once again for sharing your experiences and being with us. And we look forward.
Thank you, Sir Jai, and to all our speakers, as well as to all our participants for participating in today's webinar. All right. Thank you, everyone.
Thank you. Thank you. Bye.
Thank you.
Thank
Bye.
you.
Thank
Bye-bye.
you.
Bye.
Bye.